Hello, and welcome to Timing is Everything, a program of Care Dimensions, formerly Hospice of the North Shore in Greater Boston. My name is Mary Crow, and I'm the Education Specialist at Care Dimensions. Today, our guest is Dr. Robert Warren. He's the Medical Director of Palliative Care and the Assistant Medical Director of Hospice Care at Care Dimensions. Welcome, Dr. Warren.
Thank you for having me.
Oh, it's a pleasure. So, tell us a little bit about yourself and your role at Care Dimensions.
So I am Assistant Medical Director of Hospice and Director of Palliative Medicine. My background is I am a family physician and geriatrician, and I got interested in hospice and palliative medicine while doing a geriatric fellowship. I saw my nursing home residents go from the hospital back to the nursing home, back to the hospital, and no one really addressing what their goals were at that time. And I discovered a specialty called hospice and palliative medicine early in my career and early in it as a specialty. I have been working with Care Dimensions for 6 years now. And a lot of what I do on the clinical end is meet with families and patients and discuss what their hopes and goals are for the future. And on the other side, I help develop with our partners in the community palliative care programs at home, in hospitals, in nursing facilities, so we can better take care of community patients.
Excellent. You know, and that's, I'm really excited about this show today because, today we're going to talk about palliative care, we're going to talk about goals of care conversation and advanced care planning. And a lot of people haven't heard of most of that. So I'm really excited to have you here today to talk more about it. So talk to us about palliative care.
So in the community, and includes physicians, there's a real misunderstanding of what palliative care is. Palliative care really means taking care of people's needs for talking about their goals while they're still getting aggressive treatment, taking care of symptoms while they are still getting those interventions, and then as time goes on, really watching those goals change over time, sometimes to more comfort-directed goals.
Excellent. So, because I think when people hear the word palliative, again, it's very confusing for them because a lot of times they're thinking, palliative care, hospice care, they're all the same thing. How about talking a little bit about that?
So I'm a true believer that we often talk about palliative care when we really mean hospice care.
Mm-hmm.
I do believe we're afraid to use the word hospice, but palliative care can really begin at any point in anybody's illness. They still can be seeking aggressive treatments, maybe newly diagnosed, having uncontrolled symptoms, need spiritual and emotional support. At Care Dimensions, we have a unique service which is very clinician-based. We have nurse practitioners and physicians that see patients wherever they are. That may be in a hospital setting, it could actually be in a nursing home or at home, assisted livings. And what we do is we work with the primary team to get symptoms under control and further have these discussions on what options are available and help guide them through.
And a lot of times, people hear this and they think of palliative care really as a pain program. So help to clear that up for us.
So we are experts at pain management, and we do a wonderful job of patients that have advanced illnesses helping their primary doctors control their pain.
Yeah.
I use the example of an 85-year-old who has bad spinal stenosis, which causes back pain, will probably fall under our palliative care team, but the 45-year-old with chronic abdominal pain, that would be someone that would go to a pain clinic rather than our pain palliative care service.
Okay, that's a great distinction. You brought up too, again, palliative care. In a lot of places, people might say they're doing palliative care, but it's the same staff just kind of saying, okay, now I'll do a palliative visit. It's very different, though, at Care Dimensions.
Yes, at Care Dimensions, everybody who is part of our palliative care team is either board certified or approaching certification in palliative care and hospice care, and this is all that we really do. Yeah. We do the palliative care on the hospice side, and we really deal with those transitions of care very well. There's very few palliative care programs and hospice programs that have their own employed physicians and nurse practitioners, and that's what we really do have, a great team of people.
That's wonderful. So again, it's really physician, nurse practitioner driven, but you talked about too that if people have other needs, whether it be spiritual or psychosocial, that you have that
We bring in our
support.
social workers and our chaplains to help. We partner with VNA services throughout the community, and our partnership is such that they are doing a lot of the nursing services for these patients, but we are helping organize that with the primary team and continuing with the clinician-based services.
Okay. So that's an interesting distinction too, because again, a lot of times people are confused about this, because if hospice services are involved, they can't be on hospice care and visiting nurse services. Very different for palliative care.
So with palliative care, that would be the ideal situation of VNA services involved with our palliative care team.
Excellent, excellent. So again, any setting?
Yes, we all drive quite a bit. We see patients wherever they are. So many patients, we may be that only continuity. We would see them in the hospital setting. They go to a nursing facility for short-term rehab. We would see them there. Hopefully they go home and they're improving, and we would follow them at home. And sometimes they're not improving, and the goals change really to hospice care, and that we may still be part of that team.
Okay.
And that's the wonderful thing about Care Dimensions, is we really go across all those transitions of care.
That's wonderful. So the other thing too that you bring up, because you say pain and symptom management, because again, there's so much focus on physical pain only. Can you talk more about some of the other symptoms that could be addressed through palliative care?
So some of the symptoms, one of the biggest symptoms that we often deal with is fatigue. And it's something sometimes we can use medications for, but there's also things that we could talk about managing exertional management, taking breaks, and really helping them, do the things that would make their activity of daily living easier. Shortness of breath is another major symptom that we deal with. We use medications very similar to pain medications for what we call air hunger.
Okay.
And then I would say the next biggest area is delirium. And delirium, particularly in the elderly patient, can be multifactorial, many causes. And sometimes you can't determine what those causes are. We do our best, but there's medications and behavioral modification we can use.
Okay. And how often do you see somebody when they come on to palliative?
So we see patients in the hospital Monday through Friday within 24 hours after receiving a consult. In the community, it's sort of an as-needed basis. We usually see patients within 1 week of being discharged from a hospital or getting that consultation. If there's ever an emergency situation, we are available to give advice via the telephone or see patients as soon as possible. We follow up. We don't follow people for long periods of time, but on an as-needed basis for as long as those symptoms are needed.
So it might not just be one visit.
Most of the time it is not one visit. We
Yeah.
usually see people more than once.
Yeah, that's great. So again, we're going to talk more about this too, because you're bringing up, issues around goals of care conversation, all of that thing. Again, these are new terms to people, but I just want to talk more about, again, just in terms of this hospice distinction and all of that. Some people shy away from hospice because they feel about, giving up hope, that sort of thing. And again, palliative, again, there's really a distinction between the two. And that's a myth and misconception of hospice too. Can you talk more about that?
So, and I'm always honest, palliative care is not going to give the same support as hospice care.
Yep.
One of the things that we've really done with Care Dimension is blur the lines between hospice and palliative medicine. If patients' goals match hospice goals, but perhaps they want to continue blood transfusions, our palliative care team is really there to explain what the support of hospice would provide, and hopefully get them that supportive team of hospice.
Excellent.
Hospice is 24/7 care as far as emergency care. Someone is always on call. Where palliative care, many of these patients, despite us being involved, if there's an emergency situation, they end up in the emergency room. So we really want to get patients that goals match hospice, that qualify for hospice, to really give them everything they can and provide support so they can receive the hospice care if that's appropriate.
Excellent. So you can help with that. So this can be a bridge to hospice, or it can be, again, a service that they actually utilize independently as well.
Yes.
Yeah. So, which is really important again, because again, people again get so confused about this, and again, we don't want them shying away from either of the services, right?
Right. So, much of what we often are explaining is that this is really a continuum of care.
Yeah.
Many people will never receive hospice care, but the majority of patients that we see as their disease progresses, or as we explain the benefits of hospice, and that it's not just stopping things, but it's adding many more things, to receive the support of an entire hospice team.
Okay. Yeah, go ahead.
We are seeing changes where people are realizing that we need to provide more support under palliative care. There's a lot of studies, including the Medicare Care Choice model, that is looking to provide hospice like care earlier, why patients are still receiving aggressive treatments.
Yeah.
We already do that with our
Yeah,
open access hospice, but I do think we're going to see a change in the future for more support under the palliative care side.
Okay, great. So yeah, so again, this is great that because people assume that they can't get on service until much too late. So it's good to know that again, people are thinking more proactively in this event. So I want to ask you just quickly, how do people access palliative care? Who do they call? Who makes the referral?
So in order for us to take care of a patient under palliative care, we need to get a consult order from their primary care physician. If they call, and we will show the number for patients and families to call, we can help them do that.
Okay.
So if you're at your primary care's office and you want a palliative care consult, you can ask there.
Yeah.
You can call our office directly.
Okay.
We will reach out to your physicians to do that.
Excellent.
And we also explain to patients and families, if they ever saw us in the hospital and then they haven't heard from us because they were doing well and get re-hospitalized,
Yep.
it's a good time to request our services again.
Okay.
Because anytime goals change and
Sure.
events change, we can really help with that.
Excellent. Well, we're going to take a quick break and we're going to come back and talk more about this.
Thanks.
Care Dimensions, formerly Hospice of the North Shore in Greater Boston, is different in that we do more than just hospice.
It's just incredible, the services they provide when people need it the most.
So being able to offer more individualized care helps people feel more cared for.
Because it's about the patient's quality of life.
I don't think there's any place else in the Boston area like Care Dimensions.
At Care Dimensions, we'll take care of your family like you're a part of ours. Visit us at caredimensions.org.
Welcome back to Timing is Everything. And again, my name is Mary Crow, Education Specialist at Care Dimensions, and today we have the pleasure of having Dr. Warren here, who is the Medical Director of Palliative Care and the Assistant Medical Director of Hospice Care at Care Dimensions. We're talking about palliative care and goals of care conversation, advanced care planning. So Rob, you brought up in the first part of the show, goals of care conversation. Talk more about that.
So one of the things when people ask what we do with our palliative care team, what we tell everybody is we are a team of doctors, nurse practitioners, and nurses who meet with patients and families that have advanced illness, and we talk about hopes and goals for the future. And if someone has any pain or shortness of breath, we work on getting those symptoms under control. It's in medicine, it's a lot to digest for families when they have an illness. There's a lot of communication, there's a lot of misunderstanding, and finding out what a patient's goals are. The first part is to really get to understand what they understand about their illness. One of the luxuries we have with our palliative care team is time. We have meetings with families that can last 30 minutes, 60 minutes, sometimes even longer, and sometimes multiple occasions. And there really is a way to have these meetings. Our first goal is to make sure that we have the right people at those meetings.
Yes, yeah.
If someone needs a husband or son or daughter to be part of that conversation, we're going to schedule that meeting when they're available.
Yeah.
And I always say our first thing is open-ended. What have your doctors told you? In medicine, we often read studies that doctors interrupt within 14 seconds of a conversation.
Is that right?
But we're really trained to just sit back and listen.
Yeah, so there's a couple of different things that come from this when you're talking about this. First of all, I think there's just so much emphasis, and correct me if I'm wrong, just so much emphasis now on, again, really meeting the individual's needs and really ascertaining from them what are their hopes, what are their wishes and all, where maybe in the past there wasn't so much focus on that. The other piece that you bring up is just the skill level involved here. I don't think people understand how skilled these conversations are. You know, and again, if you have cardiac disease, you go to a cardiologist. If you have an advanced illness, you want to go to a palliative care physician who's really highly skilled in these areas. Can you say more about that?
Yes, it is family meetings and these goals of care conversation, certainly a trainable skill.
Yeah.
Just like surgery
Yeah.
or any type of medicine. It takes a lot of time to get good at this, and there is no meeting that is ever the same. So the more meetings our team does, and we do group meetings and we all learn from each other,
Yeah.
one of the things that we're really able to accomplish is really understanding the uniqueness of each family and how hopes may be unique to that family. You maybe, want to make it to my daughter's wedding,
Right.
or I just want to go fishing one more time.
Sure.
Or I want to fight this illness to the end. I mean, these are things that we can bring out, and we have time to talk about those goals.
Yeah, so you keep bringing up time, which is, again, such a critical component. These are such really intimate personal discussions that can't be rushed. And I think sometimes for people, again, seeking out healthcare treatment, they often do feel rushed. And how important is it for people to feel really tended to?
I think it's one of the most important things. Very often, as soon as we see a patient or family, things haven't been going well. 10 things went wrong in the hospital, 5 things went wrong in the nursing home, then they had to wait in the emergency room to be readmitted. And we often spend the first 10 minutes where they just vent.
Yes, yeah.
And it's unfortunate that things do go wrong, and we accept that, but we also bring them back to, we are here now,
Yeah.
and let's start this conversation. We always sit down at all our meetings. It's hard to find seats in hospitals,
Sure.
but we make sure we have a quiet place to talk. And home settings are ideal because we really get to know what the family situation's like in the home situation is.
So important about setting, isn't it? And
Yes.
then, and again, talking about, and you keep going back to it, just the skill of listening. I keep hearing that from what you're saying, and just how important and therapeutic that is. So what kind of tools and resources do you use in terms of having these conversations?
So as far as tools and resources, a lot of what we're doing is explaining what those options of care are. So some of the tools and resources that we look at are, talking about the Medicare skilled nursing facility benefit,
Yep.
and what that means, how long that usually is.
Yep.
We can use resources of social workers to talk about financial implications of that. As far as if a patient may be eligible for hospice, we sometimes, do visual tours of our Kaplan House, and pamphlets and brochures. And as far as just general advanced care planning,
Yes.
One of the most important issues that we deal with is healthcare proxies in Massachusetts.
So let's bring up a copy of that for you now, too, so that people can see a copy of this healthcare proxy. Go ahead and talk about that.
So the Massachusetts, some states have a whole statute that shows that if nothing is written down, the husband or wife makes a decision first, then the grown children. In Massachusetts, there really is no statute that shows what's happened. So it's really important in the state of Massachusetts for somebody to decide who they would want to make decisions if they were unable. And one of the things that we tell people and always make sure is just because they have a healthcare proxy does not mean that they lose their ability to make decisions.
Absolutely.
It's only in that area where if they lost the capacity to make decisions,
Yeah.
who would they want to do it? And what I always tell my patients and families is you would want someone, your son or daughter may not be the right person because they would have a hard time abiding by your wishes because of the true love that they have.
Sure.
And it may be a friend or, one of your sons or daughters may be better at these difficult decisions.
Absolutely.
But more importantly, you want to have these discussions with your whole family.
Yeah.
before that crisis moment.
Yes.
Too often, our palliative care team meets with families in a hospital setting, and everyone says, we never talked about it.
Wow.
And we
Yeah.
look back and we say, this person's been hospitalized 5 times, and it's unfortunate that we didn't get to meet with them before this crisis situation.
Well, and again, you bring up such an important point because a lot of people don't have healthcare proxies in place, right? So even though this is really a critical piece to have, a lot of people don't have these types of advanced directives.
So the thing about the Massachusetts healthcare proxy, it does not need to be notarized,
Yep.
which is a misconception. It needs to be witnessed by 2 people who are not the
Yep.
healthcare proxy.
Yep.
We encourage people to use multiple proxies. There's a listing for 1 and 2
Yep.
in case someone is not able or not willing to
Right.
help.
Yes, and that happens often, where that person that was listed for some reason becomes incapable, or maybe they become ill or what have you before that person.
Yes.
Yeah, and you bring up again an interesting point that a lot of times, even if you have the healthcare proxy, that's only part of the way. If you don't have the conversation, really people's wishes aren't always followed through on.
Yes.
And pick your healthcare proxy wisely.
Pick your healthcare proxy wisely. It's
Yeah.
I say it's the person that you have the most fun with, that when you're not having fun,
Yeah,
they're
exactly.
going to know.
Yes, yeah, because we assume again that just because it's the closest person, we don't want to hurt feelings. We really have to pick that person with our head, not our heart.
And one of the things that as palliative care specialists, even if there's a family and one son or daughter is the healthcare proxy, we really strive to get agreement with family.
Yeah.
So our family meetings never really exclude people.
Yes.
And it's a very rare occasion where we can't come to consensus, where we would just look towards a healthcare proxy to make decisions.
Oh, it's great. How about what other types of forms do you use?
So in Massachusetts, there is no statute for a living will, so they're not legal documents. That being said, it can really help guide a healthcare proxy to make decisions for what people would want. There's a living will document called the 5 Wishes.
Okay.
And the 5 Wishes basically is more than just a set living will. It goes through a whole bunch of scenarios that would be what someone's quality of life would be. It even talks about what they would want, when they're dying. Would they want peacefulness? Would they want all their family around them? And it talks about, messages they would have for their family after they died. So it's a really nice document for somebody to go through with their family because it just engages that conversation.
Well, which is really nice again, because we focus so much on the medical, but really advanced illness and end of life is so much more than that. Spirit, mind, and body. And again, if we're just focused on the physical and the medical part of this, boy, are we missing out on the person. So that's kind of a nice tool to be able to make sure that that person is, again, their wishes are followed through on in all areas. So what else do you utilize in terms of helping with these?
So one of the biggest issues that comes up in any hospital setting or nursing home setting is the do not resuscitate order.
Yeah.
And I'll use this as a time to educate people that do not resuscitate order, it's not like on television. Resuscitation is not like you see on television where someone gets shocked in CPR and they leave the ER the next day looking a whole lot better than they did the day before. There's a success rate of about 10% in a hospital, and that's for all patients. This is not a lot of the patients we would see with advanced illnesses.
Yes.
That would be a younger patient who has a heart attack or trauma in a car accident. So in so many ways, we're making such a big deal about an order that is probably not going to be successful.
Right.
And what I also tell patients and families is, what they say, why not try? And a few major reasons are, one, it's a terrible way for someone to watch their loved one die.
Yes.
And number 2, if they do survive and they're in an intensive care unit and the family has to decide whether to take them off of life support, that's a much more difficult decision.
Mm-hmm. Sure.
We have, in Massachusetts now, we have what's called the MOST, which is the Massachusetts Order for Life-Sustaining Treatment. And it's a wonderful document. It was initially started in Oregon, but I think most of the states actually have some sort of document like this now. And there's 2 sides to it. I'll just talk about the first side, which really talks about resuscitation.
Okay.
If someone's in cardiac arrest, intubation, if they're in respiratory arrest, and would they want to go back and forth to the hospital.
Sure.
The nice thing and the important thing about this document is it travels wherever a patient goes to. What that means is if I have the discussion at home and the patient is hospitalized,
Yes.
this needs to be a valid order in any hospital, whether I'm on staff at that hospital or
Yes.
not.
Okay.
So any licensed Massachusetts physician or nurse practitioner, this is a valid order wherever they go.
Okay, great. So you're talking, so in terms of the distinction, so you said the healthcare proxy, and actually that's a legal document, right, about appointing somebody who's going to make those decisions. The MOST, you're talking about a medical order form.
So this is an order.
Yeah,
So
yeah.
it becomes an order wherever a patient goes to.
Sure.
And you know, in the past, we had to have this conversation over and over again.
Yeah.
And we ended up with multiple orders. This one is a valid document and you don't have to repeat this conversation.
Excellent. Now who's the conversation with the MOST?
So if a patient is able to make decisions,
Yep.
this
It's
is
for
who
them.
is signing that order.
So between the physician?
The physician or nurse practitioner who's
Yep.
the attending physician,
Okay, very good.
they would have this conversation.
Okay, good. And then if that person is not capable, it would go to?
So if a patient's healthcare proxy has been invoked and families are all in agreement, they would sign this order.
Yeah.
A healthcare proxy can actually change the MOST form.
Yes.
So that's another important
Yes.
reason. So we've had patients that said they don't want resuscitation, but their healthcare proxy not chosen wisely
That's right.
may just have a hard time with that
Yeah.
and change it.
And I think that's an important point to make. Again, you can make that decision about your healthcare proxy and people aren't going to change that on you. But again, this can be changed. So like you said, pick that person wisely who's going to follow your wishes. See, that's the hard part. I think that people think, again, that if they're not picking that person wisely, they just assume the person's going to follow through. You got to have that discussion.
Yeah, the most important part is, discussion at the dinner table, any change of status, someone gets hospitalized, they go to rehab, every time a new diagnosis, these
Yeah.
are all reasons to continue this conversation.
Yeah, absolutely. So this isn't just a one-time deal, we're constantly reevaluating.
And just from a palliative care side, we often see patients, 2 years before, maybe they were hospitalized, they may have some pain, we talked about some goals of care, they've done quite well, and then we see them a year and a half later and things aren't going so well, but we initiated that conversation and it makes our second and third meeting that much easier.
Oh, absolutely. Do you find that people are receptive to these conversations and utilizing these forms?
I do. I think the resistance of patients aren't ready for palliative care, they're not ready for hospice care,
Yeah.
often comes from the hospital setting.
Yeah.
But when you really explain what we do, it's very unusual for a patient not to have been satisfied that they have met with us.
Yeah. Well, you brought up again an interesting point that a lot of times people are waiting and they're having these conversations in crisis mode. These have to happen way before that. So again, you're taking the time, and a lot of time you're trying to undo and to really explain what the reality of these situations are. But again, a lot of people, they're high emotions at that time.
Yeah, it's often really difficult when a family's gone down a pathway where they were thinking somebody was get better. It's often sort of this roller coaster.
Yeah,
And the reality is, if someone was talking about the likelihood of recovery, quality of life, which may mean if they're not going to live at home independently, these decisions and discussions didn't take place early, and then we end up taking care of them very
Sure.
late.
I like how you brought up too, because again, families can be in such turmoil after this, so it's so important to have everybody in a kind of a part of these discussions as best as able. So, I know we have to wrap up, but is there any one piece of info or one thing that you want to just stress to the viewers in terms of the importance of everything we talked about today?
So, no, I think it's really important for people not to worry about the distinction between palliative care and hospice and their eligibility, but to really just reach out to their physician to get a palliative care consult.
Yep.
We can really help guide them through. Many families are in crisis mode when they call us, and earlier would be very helpful.
Excellent. Well, we really appreciate you being here today. This is a conversation that we could really spend much more time on, but love to have you back at another point. But thank you so much for your time today.
Thanks.
For more information on palliative care or care dimensions, we're going to be putting information up in terms of a number and a website that you can tune into. So again, thank you very much, Dr. Warren, and thank you all for tuning in to Timing is Everything, and we look forward to you tuning into the next show.